Among the various grades of AV block, in first degree AV block and third degree AV block or complete arc block, the rhythm is regular. While in second degree AV block, the rhythm is always irregular. There will be a patterned irregularity mostly. And usual second degree AV block, only one P wave is non-conducted in a particular cycle. There is also a condition known as advanced AV block, or sometimes called as high grade AV block, which is intermediate between second degree and third degree, in which two or more consecutive P waves may be non-conducted. While in usual second degree, it is only one P wave which is not conducted in a particular cycle. This diagram illustrates type 1 and type 2 of second degree AV block. These are the Morbitz type 1 and type 2. Morbitz type 1 is also known as Wengi-Back AV block. This is type 2, and type 1 is usually AV nodal block because decremental conduction is usually a property of the AV node. While in type 2, it is block below the AV node, typically in the bundle branches, so that it may be associated with intraventricular conduction defect, like a bundle branch block may be associated, and there will be a wide QRS. Prognosis is poorer for type 2 as the conduction system is affected lower down, and if it goes into complete arc block, there is a higher chance for Stokes-Adam attacks with low rate of the subsidiary focus as it arises from the ventricle. In type 2, there is no progressive prolongation of PR interval. Suddenly, there is a non-conducted P wave with absence of QRS complex. This is type 2. So, as there is no progressive prolongation, this interval can be double of this interval. In type 1, there is progressive prolongation of the PR. Here, I have shown only 2 cycles. You can have more also. Progressive prolongation with non-conducted P wave. That is the usual feature of Wengi-Back or type 1 second degree AV block. Earlier we had seen bigeminy with 3:2 conduction. For 3 P waves, there were 2 QRS complexes in a cycle. Here it is little more than that. It is a sequence of 3. So it will be 4 P waves, 1, 2, 3, 4 P waves for a cycle with 3 QRS complexes. Here the P has come on the T wave. This is to demonstrate that sometimes P may not be seen separately in this region. It may overlap on the T wave and you may have to look carefully. Here it is easy because I have drawn it so for easy recognition, but it may not be always like that. It may be only subtle changes in the shape of the P wave that you have to look for in case of AV block. And this has to be noted: constant PP interval. PP intervals are constant in spite of the irregularity in the RR interval, and can very well see the progressive prolongation of the PR interval in the Wengi-Back sequence. In the PP interval, there could be minor irregularity if there is exaggerated sinus arrhythmia, but we will not take that into consideration for a usual discussion of Wengi-Back. Constant PP interval with varying PR interval, that is a feature of Wengi-Back AV block. And when there is a P wave which is blocked, you have a pause. That is a pause seen in Wengi-Back sequence. This is 4:3. 4 P waves, 3 QRS complexes in a cycle. Up to this is one cycle. This is the next cycle. As the pause occurs, AV node recovers and the next PR interval is shorter. This Wengi-Back phenomenon can also occur without disease of the AV node. That is known as Wengi-Back threshold of the AV node. If you pace the atrium at a fast rate, increasing rate, at a particular rate, it will show that conduction in the AV node becomes a Wengi-Back sequence. That is known as Wengi-Back threshold, which occurs when there is atrial pacing during electrophysiology study. But this is less likely to occur if you run and cause sinus tachycardia. That is because there is withdrawal of vagal tone and increase in the sympathetic tone on the AV node, so that AV conduction is enhanced during physiological sinus tachycardia. On the contrary, sometimes AV block, second degree AV block also can occur in highly trained athletes because they have high vagal tone. They will have sinus bradycardia and occasionally even up to second degree AV block. First degree is more common, even up to second degree AV block has been described in athletes' bradycardia because of the very high vagal tone on the AV node. So Wengi-Back threshold is applicable for atrial pacing and not for usual sinus tachycardia during exercise. Even when 200 heart rate occurs, there is seldom Wengi-Backing when you do a treadmill. Then atrial pacing, Wengi-Backing may occur at 160 per minute. Same can occur when there is an atrial tachycardia, paroxysmal atrial tachycardia, where an ectopic atrial tachycardia can go into a Wengi-Back sequence when the rate is high. In atrial flutter also there could be Wengi-Back sequence, but usually in atrial flutter often it's a fixed ratio block which you see rather than the typical Wengi-Back sequence. This is another feature of Wengi-Back sequence. There is progressive shortening of RR interval. You can see that this RR interval is shorter than this RR interval. That is because of decremental increments of PR interval. The maximum increase occurs from the first to second, and second to third the increase is a little lesser. That is why QRS becomes earlier, producing shortening of RR interval, a feature of decremental increments. That is, the increase in PR interval in each cycle is lesser than that in the previous cycle. That is why you have progressive shortening of RR interval. I have shown only 4:3 block. There could be higher grades of AV block, not higher grades, higher ratios of AV blocks. It could be 5:4. Always in Wengi-Back sequence, the ratio is like there is only a difference of 1. 5:4, 4:3, 3:2. So the highest ratio possible is 2:1. In 2:1, only half of the P waves are conducted. But then you will not be sure whether it is type 1 or type 2 second degree AV block. Even though we say that the highest ratio, that is 50% non-conduction, is possible in 2:1 AV block. Another feature is the relationship between the shortest RR interval and the longest RR interval in a Wengi-Back sequence. Shortest RR interval in a Wengi-Back sequence always is just before the pause, and the pause is the longest RR interval you note in a Wengi-Back sequence. Another feature is that this pause is always less than twice the shortest RR interval. This is what I have marked here. The pause will be less than twice the shortest RR interval.